Welcome to the 17th meeting of the COVID-19 Committee. We have apologies from Beatrice Wishart, MSP, who is attending another parliamentary committee this morning. I would like to welcome Willie Rennie, MSP, to the meeting, who is a substitute for Beatrice. Can I now turn to agenda item 1? The Parliament agreed changes to the committee's membership in its session on Wednesday, the 16th of September, meaning that Stuart Stevenson and Ross Greer have moved on to take up other parliamentary roles. I would like to take this opportunity to put on record the committee's thanks to Stuart and Ross for their valued contribution to our work. I would also like to welcome our new members, Stuart McMillan, MSP, and Mark Ruskell, MSP, to this committee, and can I now invite them to declare any relevant interests? Firstly, Stuart, do you have any registrable interests relevant to the committee's remit that you wish to declare?
Thank you, Convener. No, I don't have any relevant interests to declare, but just to make members aware, I am the Deputy Convener of the Delegated Powers and Law Reform Committee.
Thank you, Stuart. Mark, do you have any registrable interests relevant to the committee's remit that you wish to declare?
Nothing to declare, Convener.
Thank you, Mark. I will now turn to the next agenda item, number 2, which is the COVID-19 framework for decision-making and Scotland's route map. Members will be aware that the First Minister announced the Scottish Government's intention to bring forward new restrictions to respond to coronavirus on the 22nd of September, which are now in force. We will formally consider the secondary legislation that gives effect to those restrictions at our meeting next week. But in the meantime, this morning's evidence session is intended to be quite an open session where the committee is able to ask ministers and officials about how the latest restrictions fit into the Scottish Government's wider plan to respond to the pandemic, what lies ahead. And we are joined by John Swinney, MSP, Deputy First Minister and Cabinet Secretary for Education and Skills, and Jean Freeman, MSP, Cabinet Secretary for Health and Sport. The ministers are supported by Scottish Government officials, and they are Professor Jason Leach, National Clinical Director, and Richard Fogo, Director of Population Health. Can I welcome all of you to the meeting and thank you for attending. Deputy First Minister, can I first invite you to make an opening statement?
Thank you, Convener, and good morning to members of the committee. Over the summer, Scotland has made major progress in tackling the COVID-19 pandemic. We have progressed cautiously through the route map phases, taking care at every step to ensure it was safe to proceed. At times we've had to pause and take a little longer to make progress, but we have now reached a point in phase 3 where around 96% of our businesses are trading again, though many will be operating below full capacity. Our children have returned to school and many social activities have been able to resume. However, the virus is spreading again. The R number has been above 1 for several weeks. It may currently be as high as 1.6. We have already responded with new measures, further restrictions on social gatherings, including not allowing meeting another household within our homes, and a 10 p.m. curfew on hospitality settings. If we need to go further, we will do so. We need to bring the R number down rapidly back below 1, so that the virus returns to a downward trajectory, and we need to suppress the virus back to very low levels again. Our route map describes an evidence-led, transparent and phased approach to varying restrictions. To judge whether and when restrictions can be changed, a range of evidence is considered on the progress of the pandemic in Scotland, including what we know about the reproduction rate, the R number of the virus, and data on the number of infectious cases. The route map is linear in the sense that it charts a course from the height of lockdown towards the new normal in phase 4, when the restrictions can be lifted. However, it has built-in flexibility to enable us to respond to the evolving challenges of the crisis. We have used phase criteria to determine whether it is safe to proceed with further easing of restrictions. And when the data tells us that it is not safe, then that allows us to pause changes, as we did at the last review on the 10th of September, and to reintroduce restrictions where these are necessary. We have always said since the start of the route map that phase 3 would bring outbreaks. They come with the reopening of the economy, public services and broader society that alleviate the broader harms of the crisis. What we must now do is take effective action guided by the evidence to keep those outbreaks in check. We are making changes at a pace and at a level that we think is right and safe for our current circumstances in Scotland. The deteriorating status of the epidemic means that decisions need to be taken quickly on the interventions required to suppress the virus again in Scotland. Other countries in the UK and across the world are grappling with a similar situation. That is why we have already put in place further measures across Scotland to tighten our restriction on social gatherings. These are necessary to reduce the spread of the virus from one household to another. In doing so, we are both seeking to suppress the virus to very low levels and to protect people's jobs and livelihoods, while enabling our children to go to school and key public services to continue. This is consistent with our four harms approach, which involves suppressing the virus first and then seeking to minimise the broader harms caused by the crisis. On Sunday, we published guidance which explains how the current restrictions on social gatherings apply to students living away from home. This guidance applies from Monday the 28th of September and should be read by students alongside wider Scottish Government guidance, as well as any local restrictions in place in their area. Our principal defence against the virus remains human behaviour. Physical distancing, following the facts guidance, measures like test and protect and other wider mitigations can help, but must be deployed to maximum effect. And ultimately, it is what we all do that matters most. Thank you, Convener.
Thank you, Deputy First Minister. Cabinet Secretary Jean Freeman, can I ask you to make an opening statement if you would like?
Very much, Convener, and good morning to you and to your committee members. I'm grateful for the opportunity to be with you this morning. I know that you are all acutely aware that we're now 6 months into this country's response to the coronavirus pandemic. We have asked a very great deal from people who live in Scotland to follow measures which deviate from previous habits and change our way of life. And I cannot repeat often enough my heartfelt thanks to people in Scotland who have helped to reduce the spread of the virus and have saved lives as a consequence. But as we move into autumn, we are seeing an upsurge in cases of transmission. And as the Deputy First Minister has just said, the R number is our indicator of spread and provides us with a very short time frame to take action. As you've heard and as you've said yourself, on the 22nd of September, the First Minister announced a new set of restrictions to protect the population from the spread of COVID-19. These are difficult decisions to make throughout the response to the pandemic, and these decisions on the 22nd of September were no different. We see these new measures as a necessary action to prevent a resurgence in community transmission of the virus and the potential for a rapid return to the pressures we experienced earlier in the year. The new measures, as you know, focus on no household visits and a 10 p.m. closing time for hospitality. Like every decision, there are many factors at play. Our response to the pandemic is informed by clinical and public health advice, which ensures the health of the population takes a priority. However, I know, and we are very conscious, the harm that lockdown can do to the economy, in particular to the hospitality industry, and importantly to the mental well-being of the wider population. That is why, as we make decisions, we try as far as we can to balance the protection of life and the care for those who are most at risk from harm from the virus with fairness and with quality of life. On the analysis of Public Health Scotland and the Chief Statistician, we took a decision at a pivotal point in the upsurge of transmission to reintroduce these measures. We also looked beyond Scotland's borders when modelling our work and taking on evidence. A review of international experience following the first wave showed us that countries which implemented non-pharmaceutical interventions earlier had lower levels of hospitalisations and deaths than those which delayed. The shape of the epidemic curve in Scotland has followed a similar trajectory to that of France, with a lag of about 4 weeks. France is now experiencing an increase in hospital and ICU admissions. position which we want to avoid as far as we can. On that basis, the package of further measures to reintroduce transmission was introduced as an early intervention. As the Deputy First Minister has said, in the four harms approach, these measures are given careful and close consideration. They are undertaken in collaboration with the Chief Medical Officers Advisory Group, informed by contributions from the COVID-19 National Incident Management Team, the COVID Strategic Insights Group, and our own government senior clinical and policy leads. Our previous experience of the virus has shown that it can spread very quickly from one person to a much larger number over a very short period of time. That is why we took the decision to apply the restrictions at a national level rather than take a regionalised approach. For communities and local authorities in Scotland's Highlands and Islands, this decision was understandably met with questions. I understand their frustration and their questions at this approach and their desire to protect local businesses. However, for those island communities, despite the natural barrier to transmission, there have still been cases of infections following the initial lockdown period that we had earlier in the year. Special exceptions based on geographical location would need to come with and be balanced with travel restrictions, in this instance, to and from the islands. Both the health risk and the challenges posed by lockdown to the economy and local businesses of those communities were carefully considered, and on balance we decided to implement national measures applicable to every part of Scotland. As a Cabinet Secretary for Health and Sport, my priority is to protect and improve the health and well-being of the people of Scotland. Supported by clinical advice, I believe these new measures enable us to do that in a collective effort to continue to deal with the pandemic. I'm grateful to you, Convener, for the opportunity to make those short opening remarks, and as always I'm happy to answer questions that committee members may have.
Thank you, Cabinet Secretary. And I will now turn to questions. And if I may begin by asking the first question. This committee frequently debates the importance of public consent or buy-in to public health measures imposed by government. And we saw last weekend, when it came to the rules relating to students, that there is a need for clarity, consistency, and as much notice as possible. And without that, it's difficult to achieve buy-in. With that in mind, and looking to the future, can I ask about two events coming up? The first is that there's been quite a lot of speculation about a mid-October circuit breaker lockdown. Can I ask if that is likely? And if so, what form it will take and when we will know the details? And perhaps both the Deputy First Minister and the Cabinet Secretary could answer that.
Let me begin, Convener, with an answer to your question. The government looks carefully on a daily basis, and indeed several times a day, at the progress of the epidemic and the progress in individual parts of the country. So we are constantly considering whether there is a need for us to take more or less action depending on the prevalence of the pandemic. So all of these issues are kept under review, and as the Health Secretary and I have both made clear, we take decisions based on the evidence put in front of us about the prevalence of the pandemic, and what, based on a multiplicity of advice from a clinical perspective and from a wider policy perspective, we need to consider in coming to decisions. Now, the question of some form of circuit breaker in October has been suggested by the advice that has emerged from SAGE. I wouldn't say that that is a specific proposition. It is more the raising of the possibility that if the pandemic continues to grow at an accelerating rate in the period going forward, there may be a necessity to take some form of what I would describe as interruptive action to try to slow further and more aggressively the development of the pandemic. Now no decisions have been taken for that to be the case. The suggestion has been made, the elements and the circumstances are being explored, but it would be dependent on, I think, two fundamental elements being made more certain. One was whether there was a necessity for such an interruptive action of that type, and secondly, some detailed work which is being considered on what that might involve. But I stress, no decisions have been taken to that effect, but the purpose of it would be to take a more aggressive interruption of the development of the pandemic if that was judged to be necessary closer to the time.
Thank you. I don't know if the Cabinet Secretary for Health or her officials want to add to that.
To, in a sense, the other part of your question, in addition to what the DFM has said, in terms of how we consider whether or not we ever need to take additional actions, you will know, Convener, as will your colleagues, that there is always a time lag in implementing levels of restriction or releasing them and seeing the impact of those, whether or not they have produced in this instance, the restrictions introduced on the 22nd of September, whether or not they have the effect that we are looking for, which is to bring the R number down and continue our overall strategy of suppressing the virus as low as possible. So we're only a week in, and I know it can feel frustrating that we don't give definitive answers at this point, but that is because rightly we need to see what impact are those measures having on our overall objective of reducing the infectious pool and the R number in the Scottish population. The other point I wanted to make in terms of your very correct point about compliance. Compliance rests on trust, on people trusting what we are saying and the basis on which we are saying it, and that we are saying that clearly. We conduct consistent checks with the public in terms of how well they understand what we're saying, how well they are implementing that, what their level of implementation is. I'm pleased to say that consistently over the period, the level of trust in the Scottish Government and in our clinical advisors remains very high. Where we see that there may be groups of the population that are either not particularly understanding as clearly as we need them to exactly what we're asking them to do, or are not implementing all those measures to the degree that we want them to do, then we can modify our public information campaigns in order to target where there may be gaps, and we do that again persistently and consistently. And as we learn more and more about this virus over time, we learn more and more about how to keep the public informed and keep them with us. And in that regard, we're particularly aided by Professor Stephen Riker, who is from St Andrews University, as you know, and a member of our CMO advisory group.
Thank you for that. The other event that I was going to ask about is Christmas, which is 3 months away, and I entirely accept that at this point in time we don't know where we will be in terms of transmission and the R number at that point. But in terms of planning, given it's an issue for students returning home after term time, could you outline what planning is happening and that the government, and can you reassure the committee that the government has that firmly in view?
The government does have that issue very firmly in view. Christmas is an incredibly special time for families the length and breadth of the country, and we would want to minimise any impact and effect on individuals and families being able to gather together around Christmas time. But of course, we are living in very, very unusual times with the extent of the pandemic and the threat that it poses to the population. In relation specifically to students, we have obviously gone through a process of of supporting students as they embark on the start of the academic year. And a large number of students have moved into student accommodation. We obviously have some challenging outbreaks in different parts of the country that are being managed, and support is being provided to students. And the Higher Education Minister, Richard Lockhead, will make a statement to Parliament with further detail on those steps this afternoon. But a crucial part of our thinking is about how we can make sure that students are able to be with their families over Christmas in the way that they would normally be able to do so if they wish to do so. And that forms a central feature of the steps that we're taking with universities to make sure that students can participate in the Christmas break in the fashion that they would ordinarily be able to do so and would want to do so. And obviously we heard some thinking yesterday from the United Kingdom government on this question, and we are working closely with the United Kingdom government on many aspects of these questions.
Thank you for that answer. My final question is a health-related one, and I would be grateful for the Cabinet Secretary for Health's view on this, as well as Jason Leach's, if possible. But it's regarding the subject of household transmission. And I think I'm right in saying that restrictions have been in place in the west of Scotland for several weeks. And in fact, in Glasgow, East Renfrewshire and West Dunbartonshire, they've been in place for almost a month. And therefore, I think it would be reasonable to gauge their efficacy at this point in time. And I suppose my question is a slightly basic one, are they working? Are we seeing a reduction in transmission of the virus?
So thank you very much, Convener. I will say a few words, and then Jason will be able to give a more detailed response. I think overall, we are seeing, in terms of the non-student related cases in Greater Glasgow and Clyde, and of course we have to be clear that has added to the number that the Health Board and the local health protection team, and indeed Test and Protect, are dealing with. What we were seeing was what was described as a blunting of the number of cases. So we had not got quite to the point where we started to see it dip, but we were seeing the rise being blunted. Now, I think it's probably appropriate at this point that as a layperson, I ask Jason to come in and explain exactly what blunting looks like and where he thinks we are now with those restrictions.
Thank you, Cabinet Secretary and Convener. It's a tricky question, to be honest, to answer definitively yet, partly because of the mixed picture we now have in light of the outbreaks in higher and education. To separate that young group out, and that's the only real way you can do it, you just have to take the age group, which isn't definitive. They may not all be students. Some of them may be in workplaces. You have to take them out and look at it. And the National IMT has done that to the best of its ability and continues to do it. And their position remains two things. One, the acceleration is slowing, but the numbers aren't tipping over. So we're not seeing a reduction in the R number yet. The other thing they have said is they think the restrictions are appropriate. So that's a public health position. That's not a decision. That's the public health advice from those local teams and those 7 local authorities have suggested that that position remains the appropriate position for that population. And you can then see us take most of those restrictions and apply them nationally using the advice of the national advisors. So we are hopeful, but we can't give you a definitive answer. The only other thing I would add is I am not surprised. 4 weeks, unfortunately, for this virus is not long enough. If it were norovirus with a 12-hour incubation period, I would know already. This virus has an incubation period of 7 to 14 days, and therefore 2 incubation periods could be 4 weeks. 3 incubation periods could be 6 weeks. And if you look at Spanish data or French data, you begin to see the move through the population in incubation period chunks. And no matter what we do with population interventions, there's nothing we can do about the incubation period of this particular nasty virus. So we have to do what we think is appropriate for, unfortunately, a longer period of time than the population would like, of course. And it goes to one of your questions earlier, Convener, when you asked about pace of decision making. And it's the only bit that I can't guarantee you we won't have to do. I can guarantee you we'll try and be clear and we'll try and be consistent, but I can't guarantee you we won't have to be quick.
Thank you very much. That's incredibly helpful to me. Can I now turn to the Deputy Convener, Monica Lennon?
Thank you, Convener. Good morning, everyone. Can I return back to the issue of a circuit breaker lockdown? I take from the answer here that everything is under review, so nothing is ruled out. But can I ask, just for some clarity, is the circuit breaker proposition under active consideration? And perhaps Deputy First Minister could address this. Would it be, in your mind, necessary for schools, colleges and universities to be closed down for it to be effective? And perhaps the officials could say a bit more about what exactly would necessitate and trigger such an intervention. I know that the Deputy First Minister sort of talked around that, but what exactly would need to be happening in the country for such a circuit breaker to be considered to be essential? Thanks.
Convener, let me say a few words first of all, and then perhaps best if Professor Leach makes some comments as well. Monica Lennon is correct that the circuit breaker concept is being explored simply because we have a suggestion that that may be an effective or necessary intervention from the thinking that comes out of SAGE, and of course the government looks very carefully at the material that emerges from SAGE. What I would say, however, is, and to reinforce this point, no decisions have been taken to take such a step, nor have we had advice so far that says such a move would be required. In relation to schools, frankly, the last thing I want to do is to have to close schools. We've gone to a great deal of effort with the support of staff and local authorities, parents and pupils to reopen our schools. Generally, that process has gone well. Attendance is high. There is very little evidence of in-school transmission of the virus. It's minuscule evidence of in-school transmission of the virus. So I want to make sure that we are able to sustain full-time education for children and young people to the greatest extent possible. So obviously in October, as Monica Lennon will know, there are planned school holidays. They vary to an extent from a week in most parts of the country to the 2-week tatty holidays that will start here on Friday in Perthshire and Angus and Dundee, and stretch to maybe 10 days in some other local authority areas. And that will be over a 3-week period starting this Friday. So the schools will be off for their normal holidays, and obviously those go ahead as planned. And I think it's really important that we have that break in the school period. It's what staff and pupils are entitled to, and we should see that take its course. Obviously, the question of what would be the composition of a circuit breaker is a question to which I can't give an answer today because there have been no decisions taken on that question. But I think the general thinking behind it is that it would represent an opportunity for us to essentially slow down connection between individuals within our society. Now, we've already taken steps, the First Minister's announcements last week to essentially say that household visiting couldn't take place across the country was a measure to slow down the level of social interaction within our society. And a circuit breaker, I suppose, could best be described as taking that process to a further extent in slowing up that social interaction. As to what necessitates such a step, then I think Professor Leach could provide some guidance to the committee on that question.
Thanks, Deputy First Minister and Deputy Convener. As we learn more about this virus globally, different ideas arise. So it's hard to understand how quickly we are having to learn. Nobody has ever done this before. And it's important people don't underestimate the challenge that the advice is, never mind the decision making. So not only is the Deputy First Minister correct in that there's no decision about a circuit breaker, there is no advice yet, definitively, about a circuit breaker pretty much anywhere in the world. Let's go back to what this idea is. And this idea comes from other countries, and other countries are considering it. If you have an R number that is somewhat over 1, probably not too high actually, probably just over 1, could you put in place something like a stay-at-home order for 2 to 3 weeks that would buy you time for the pandemic to slow, to decelerate into the winter? Then you could go back to wherever you were in your country's route map or your journey out of this virus, and you would have bought yourself a period of time to allow you to get through what will be a harder winter period. Nobody has ever done a circuit breaker. Nobody has lived through a circuit breaker. It's modelling that suggests if you do it, for example, for 14 days, and most of the models are a fairly extreme version, so they are stay at home unless you have to essentially move, with or without schools. So the Deputy First Minister is correct. People model that with schools open, with schools closed. Some countries model it with hospitality open, with hospitality closed. All of those things, those variables have to be taken into account. You might, for example, buy yourself 28 days of lower risk in your pandemic. You then have to make a choice using your modelers, using the demographic you have, using the communication ability you have with your own population to decide if that's the right thing to do. My final point is a circuit breaker is not the answer. The answer is whole population measures all the time until we get science to get us out the other end. A circuit breaker would just be a help on the way, potentially. Some modelers suggest you should do it repeatedly. So you should do 2 weeks, open for a period, 2 weeks again. But that has implications for economy, implications for society, implications for schools that have just been illustrated. So it's a very, very difficult balance about whether we think this new iconic measure would be something we would recommend for Scotland, and then the decision makers, Mr. Swinney and Ms. Freeman, would then have to actually decide whether to do it or not. It is not the whole answer, but it may be part of an answer.
Thank you, Professor Leach. Can I just press a little bit more about what the triggers might be? You mentioned the R number. So when the modelers do the different scenario planning, what will be taken into account? Will it be a big spike in cases, a big increase in people going into hospital, more people dying from the virus? What is the sort of package of triggers that will be looked at when it starts to feel like it's getting out of control? Clearly we're not at that point yet, but could that be in 2 weeks' time? So I'm just wondering, what would the thing that would tip it over to make this feel like it had to be triggered?
Predictably, there isn't a single trigger. There is an assessment of the state of the pandemic across the whole of the UK, in fact, and across Scotland, that would be made by a number of advisory groups, from the Joint Biosecurity Centre to the Stage Group to Scotland's versions of them to the individual advisors like me and Gregor and Fiona, the chief nurse, and then into our command structure, if you'll forgive the expression, to the Cabinet Secretary for Health and others. But the list is not dissimilar to the list you just gave. The R number, the prevalence rate, the number of outbreaks, the ability for Test and Protect to manage those outbreaks, the overall number of cases, the positivity rate. A circuit breaker, though, it's important. A circuit breaker is not something you would do when the pandemic gets out of control. If the pandemic gets out of control, the advice will be national measures to restrict movement, to restrict engagement between households. That will be the public health advice if we get out of control. We're not out of control, but we are accelerating. So it's a very important distinction. Just now, we are relying on human behaviour and test and protect. If those two things can manage the acceleration and tip us over and get us back to reducing numbers, then more national measures won't be required. We're not sure, just as no country is sure, if that is the case. So could you, if your R number is 1.3, 1.4, could you introduce a temporary measure, a circuit breaker, that would just get that down quickly to allow you then to buy yourself time into the winter? And that's what the modellers are working on just now. And they have a variety of scenarios to present to the decision makers about whether that should include schools, whether it should include tourism, whether it should include hospitality, or whether we shouldn't do any of that. And we should continue with our approach, which is illustrated by the Cabinet Secretary, of national restrictions, easy to explain across the whole population, horrible, but easy to explain to reduce the transmission across the whole nation.
That's very helpful, Professor Leach. Can I just come back to the Deputy First Minister, and with that in mind about a possible interruptive action, I think about a week ago the First Minister had said that if she had more levers, more borrowing powers, she might wish to go further with the curfew on hospitality and maybe close the pubs entirely. Can I ask the Deputy First Minister, is it the government's view that pubs should still be open? And if there's been that hesitation about the financial impact on businesses, and if government feels that you can't do enough to support those businesses, how much would that influence your thinking around something like a circuit breaker? Would you need to get additional support from the UK government?
Throughout our discussions on the pandemic, Convener, we have taken an approach which has sought to address the 4 harms that we identified in the route map or the framework back in May. And of course, within that framework is the whole question of economic harm to individuals and businesses. So we take we make an assessment based on what is possible and practical to do to make the greatest impact on all 4 of those harms. Now, clearly, if we face a situation where the prevalence of COVID is to such an extent, if it's accelerating to such an extent, there will be, frankly, little debate about what needs to be done. We will just have to address those circumstances if the rate of the virus spreading grows too fast. So the decision making becomes far sharper, frankly, when that prevalence becomes higher. So that the question of financial support is an important element of what we are able to do. If, for example, we had more financial flexibility, we could take more moves which might get the R rate down to a greater extent in a shorter period of time. But we have to take account of the fact that if we did those measures without financial support for businesses, we might create more economic harm to individuals, and we need to balance that against the prevalence of COVID in that decision-making process. So undoubtedly, having more financial flexibility would enable us to exercise more choice and more judgments. But I would want to reassure the committee that if we see the prevalence of COVID moving to such an extent that we have to take action, we will take action to ensure that the population is protected from the growing prevalence of COVID.
Thank you, Deputy First Minister. Back to you, Convener.
Thank you, Monica. Can I turn next to Stuart McMillan, please?
Thank you, Convener. First question is to the Cabinet Secretary for Health. Yesterday it was announced there was to be an additional £1.1 billion for the NHS boards and the local health and social care partnerships. Can the Cabinet Secretary provide some information, please, regarding how this money is to be invested and spent, and is there a particular narrative for this to help with the remobilisation of the NHS services?
Thanks very much. The 1.1 billion has been calculated on the basis of the two things. First of all, each individual health board's Q1 expenditure, additional expenditure on measures necessary to respond to the pandemic, and Health and Social Care Partnerships evidenced additional expenditure for the same purpose. But we have also then built into that, in consultation with the Health and Social Care Partnerships Chief Finance Officers and with Board Chief Execs, a forward projection about the coming months, and included in that is additional resource to help remobilise the NHS, bearing in mind that we have two other significant asks of our health boards. First of all, to support the NHS Test and Protect programme, and secondly, they are the lead organisations in the delivery of the expanded flu programme. So all of those factors are in play in all of this. The way in which the resource will be disbursed is relatively new. It is essentially a hybrid approach where we will use the NRAC formula in terms of boards, but recognise that some of our boards have been disproportionately affected in a greater way than others in their response to the pandemic and their necessary expenditure. So where there has been expenditure beyond what their NRAC formula would give them of that 1.1 billion, then that will be met as well. And in terms of Health and Social Care Partnerships, it is paid against actual expenditure with, again, that assurance for the coming months. I also, at the same point, as I'm sure you know, said that we would return to this in January and look to make a further allocation at that point.
Thanks very much for that, Cabinet Secretary. That's been very helpful, and should anyone watching this session found that information to be very useful too. I've got a question for you also, just regarding regarding services that are provided in smaller hospitals across Scotland. Obviously, that there has been an approach that appears that the larger hospitals seem to have potentially more services, which I think is fully understandable because of the additional capacity that they will have. But is there an expectation with the remobilisation to have more services being rolled out across the smaller hospital estate across the country?
So I'd want to make 2 points, I think, in response to that. Our larger hospitals don't have more services just because they've got more capacity, i.e. they're larger. This is clinically driven. So where we have the need for a service that, in terms of the volume in a particular population area, would not be as clinically viable as it would be if you multiplied it by the demand in 3 different population areas, for example, then you will get clinically better outcomes by dealing with those 3 population groups in one location. If we also look at something like orthopedics, for example, this is one of the central tenets behind the elective centre programme and approach, is that being able to do high volume procedures produce both better outcomes for patients, but also significant improvements to the procedures themselves in terms of what clinicians are learning and doing, but also in terms of time spent in hospital, pain relief, and a whole range of other measures that come from that higher volume throughput. So there are 2 rationales, if you like, for why we would cohort some services into larger hospitals. That said, one of the major requirements in the remobilisation plans that I have commissioned boards to undertake is to secure a significant focus on primary and community-based healthcare. And that is it reinforces the approach that has been there for some time about shifting the balance of care. It follows through on the programme for government commitment in terms which are cohorted in two main themes, one being public health, an excellent public health service in Scotland, and a greater focus on population health. But it also capitalises on some of the innovations and improvements that emerged as a consequence of the health services response to the pandemic. I'm thinking there in particular, not exclusively about the use of digital technology, but also the expansion of the hospital at home programme, for example, which sees individuals, many elderly, but not exclusively so, receiving treatment at home from clinicians and others, which, if that was not available to them, would require a hospital admission. So the focus is very much on primary and community care, as well as, I hope, that helpful explanation about why you see some services cohorted into our larger hospital estate.
Thank you for that, Cabinet Secretary. And I've got one final question, and that's just regarding the dentistry. And in between each patient, there's a fallow time of 1 hour. Is that period of time, is that being looked at again to potentially reduce that to allow more patients to be treated?
The officer looks at this all the time with our other clinical advisors and with the professional bodies to try and see what more we can do to increase the level of service offered through our NHS dental practices. That includes looking at whether or not that time for necessary cleaning and so on to ensure patient and staff safety can in any respect be reduced but still remain as safe, as well as looking actively to see if we can bring in more quickly the full range of NHS services. So he has that work currently underway, and I would hope that we would be able to reach a conclusion on both of those very shortly.
Thank you very much. Thank you, Convener.
Thanks, Stuart. Can I turn next, please, to Mark Ruskell?
Thanks, Convener, and good morning, everybody. I'd like to start my questions by asking the government about the objective that's in the university and colleges guidance to reduce the number of people on campus. How's that going?
The guidance that the government made available made clear that we envisaged an approach of blended learning being undertaken. So there would be elements of face-to-face teaching, there would be elements of online learning, and universities would be, and colleges would be exercising judgments about the number and the volume of individuals they could have on campus based on taking the range of mitigating actions that are set out within the guidance that's been published.
Well, I thank you for that response, but I mean, in terms of the actual nature of blended learning and the numbers of people who are on campus at the moment, we're still seeing concerns. I mean, you know, John, you'll be aware of the concerns from staff at Perth College about a resumption in face-to-face teaching and attendance on campus. You may also be aware of the situation at St Andrews, where there is now continuing disagreement between staff unions and management about a phased reintroduction of face-to-face teaching there. Now, when I raised this to the First Minister back in August, she said that staff should not be put under pressure to do things that we would not advise. So what is that ultimate advice from the government? Is the advice still that where possible, the default should be working from home, because what I'm seeing is a resumption face-to-face teaching. And of course, our campuses at the moment are full of young people, although they're locked down in student residences.
The guidance envisaged that there would be an approach to blended learning, which I set out in my earlier answer. And that obviously involves an amount of face-to-face learning, but I think it would be, my assessment of it would be that face-to-face learning is being kept at a limited level. And I think that would be the appropriate step to take, consistent with the guidance that the government has issued. I think it's also really important, and this goes to the heart of the whole nature of the approach that we've taken, not just in the university and college sector, but in every sector of our society, that the importance cannot be stressed enough of high quality dialogue between employers and their employees about the approach to be taken in all of this respect, and that we'll make much more progress in dealing with the practical implications of COVID and the recovery that we've got to make from COVID if there is a good, positive partnership approach to the resumption of activity, where the concerns of members of staff are taken into account and where these are reflected in the approaches that are taken. I think it's really also important that I stress the fact that the guidance that's been put in place involves a series of mitigating actions, and it is really important that those mitigations are followed to make sure that we are creating a safe environment for everybody that is involved. Now, the teaching environment in our universities and colleges will be very, very different to what it was pre-COVID. And there is no resumption of, and can be no resumption of, the large-scale lecturing environments that have been the case in the past. We simply cannot have that many people together in the same place at the same time. So the guidance envisages, for example, much smaller limits on the number of individuals that can be educated together, with very strict mitigating factors necessary to be in place if such teaching is to take place. So I think the key point for me is that the guidance must be applied in its entirety, and secondly, that good and high quality dialogue between university and college leaders and staff is essential in taking forward this approach.
Well, I look forward to an improvement in high quality dialogue in some of our institutions, which seems to be lacking at the moment. But can I also ask about testing? I read last week that Cambridge University are now moving to a regime of testing all students weekly, regardless of whether they have symptoms or not. They're doing 16,000 tests weekly. They're not using the Lighthouse lab. They're doing this with their own facilities. And their purpose for doing this is to try and break any chain of infection that may build up within the student community. A number of universities are now looking at this and potentially looking at implementing a similar regime. Is that something we're looking at in Scotland? Is there a danger that we get left behind? Should we not be focusing on really testing people who are asymptomatic, where we can do that, and where people are at higher risk of infection?
Let me say a few words to this, but I think it would be better if Professor Leach or the Health Secretary perhaps said a bit more, because they're obviously very close to all of the policy issues on testing. But from a higher and further education perspective, the policy approach that we have taken has been consistent with the policy approach taken on testing within Scotland as a whole, as agreed in the government based on public health advice, which has been fundamentally to test symptomatic individuals, for very good reason that asymptomatic testing has been judged within our strategy and our strategic approach not to be a particularly valuable use of testing resources, given the fact that it doesn't necessarily provide us with the reassurance or the assurance of what other measures and circumstances should be addressed as a consequence. So we have in place adequate testing resources for those who require tests just now in Scotland. We are of course expanding that, and I'm very grateful to the Health Secretary for the priority that she has given to the expansion of that capacity in locations convenient to our university communities. So we've seen the expansion in St Andrews, in Glasgow, we saw it in Edinburgh, it's now in a few days will emerge in Aberdeen and also in Stirling, and there will be further rollout beyond that. So the availability of testing capacity has been an important priority, but I want to hand over to the Health Secretary or Professor Leach to give some further detail on the efficacy of asymptomatic testing.
Thank you very much. I do want to make a couple of points and then ask Professor Leach to add some further points to what both DFM and now I will say. DFM is absolutely correct. We have a revised, refreshed testing strategy which was published in the summer, and that makes clear the basis on which we approach the use of testing as one of the steps. It should never be seen as the only step, but as one of the tools, if you like, we have in understanding what is happening with the virus and attempting to both clinically treat those individuals who have symptoms and test positive appropriately, but also understand and capture those with symptoms, primarily a lot now through the Test and Protect programme and through the app, which now has 1.3 million downloads. We do use testing in one specific case in terms of asymptomatic individuals, and that is our weekly care home staff testing programme, which tests on an average of around 37,000 staff every week. That is there to prevent the introduction of the virus into care homes where we have our most vulnerable citizens, vulnerable in terms of the harm that the virus can do to them in making them seriously ill and indeed making them more likely to die as a consequence of it. The First Minister, the Deputy First Minister has also said quite rightly that we have introduced the walk-in centres, and as he said, we have St Andrews, Glasgow, Aberdeen, Edinburgh. Stirling opens on Monday, and the second Glasgow centre opens this Friday. We then move to Dundee, and then we pick up other parts of the country that are less about concentration of the student population, but are more about making testing resource, sampling resource more accessible. So looking, for example, at Inverclyde, as well as parts of the Highlands and Western Bartonshire. So the final thing I would say before I pass to Professor Leach is you'll be aware that we have the two, if you like, testing routes in Scotland. One is through where the samples are taken and are then processed through the Lighthouse lab, that is part of the UK network. The other is our own NHS labs, which have been scaled up, which are now subject to significant further increase through the introduction of regional hubs, which will expand the capacity we have through the NHS to process samples. That will allow us to complete the current programme of work, which is migrating our care home staff testing from processing through the Lighthouse lab, and therefore subject to any reduction in processing capacity for those tests taken in Scotland as a consequence of surging demand for the UK as a whole, and ensuring and protecting the processing of those samples for care homes. As we expand the capacity to process tests in Scotland through the NHS further, we will continue to look at what more we might do to use testing as one of those tools that we have to interrupt the transmission chain of the virus and protect our citizens. Perhaps Professor Leachlow might want to say something just about the asymptomatic the approach to testing asymptomatic individuals.
Thanks both, and thanks for your question, Mr. Ruskell. I don't know the Cambridge story specifically, so we should look into that and see exactly what they're doing. I imagine, I'm guessing, they're also introducing considerable travel restrictions on that population. So Cambridge tends to live in campuses behind gates, so asymptomatic testing in bubbles makes more sense than asymptomatic testing outside bubbles, where people are still engaging in society. So elite sport does asymptomatic testing inside bubbles, but you're not allowed to leave the bubble. You're not allowed to go to the chemist. So there are ways you can use asymptomatic testing, of course, but let's remember what the test does. It looks for genetic material of virus, either live virus or remnants of live virus, which people can shed for up to 6 weeks following infection, and they're not infective. So there are extensive limitations to the present version of testing. Now, one of the ways out of this pandemic is a different form of testing that would be quicker, that would be more reliable, that you could roll out at a population level in Palestine and Israel, and in Scotland you could use it all over the world. That is not with us just now. So asymptomatic testing has a role, and we seek advice on how we should use it from virologists, from the advised scientific advisory groups, from the education advisory group, from SAGE. We then bring all that evidence together, compare it to our capacity, of course, because there is a finite capacity of testing, even though our testing is now at the top of the league table by population in Europe, but there is still a finite capacity. We then give advice about choices, and that's laid out in the testing strategy that you've seen us publish a number of times, most recently just a few weeks ago, about what we think those priorities should be. Having said all of that, we keep that under constant review. So if there is learning from Cambridge or from Duke in North Carolina, who are doing a similar programme, which we're watching and paying attention to, if there is learning from that influences those decisions, of course we will think about them, and of course we will advise appropriately.
Can I just perhaps, Convener, just come in with one last question? And I think those are very useful responses. I mean, there clearly are some universities in Scotland that have more of a sort of a bubble around them than others, and particularly if they're like Stirling University, for example, a campus away from town. So anything the government can do to look at rolling out more asymptomatic testing would be very useful to hear about. But Professor Leach, you mentioned about rapid testing, and we've heard the news this week that WHO are assessing for use a number of rapid tests. They aim to make 120 million of those available in low-income countries. But when do you think in Scotland rapid tests may be available?
So it's unfortunately not this test versus the new fancy 3-minute test. There will be a scientific progression through testing, and as you miniaturize and as you speed up, traditionally you lose specificity. So as you get smaller and quicker tests, test gets slightly less reliable. So you would tend to use it, for instance, at a population level where you're not making individual decisions about treatment, you're making decisions about population restrictions, for example. That may well come quicker than being able to test at home and give yourself a red or a green and let you know whether you can go to work that day. That is a long way off, despite what you read in some journals and some media. We are already testing faster tests. We already have some machines which we're assessing. We're giving them to our laboratories. We can do things like test the PCR test, the normal test, so let that proceed as normal, and take that same sample and use it in one of the new machines to see if we can get the same results as the drug companies or the manufacturers suggest you can get using their machines. So that is ongoing. That happens all the time with tuberculosis testing or sexually transmitted disease testing or whatever. So we're doing that. We're speeding it up. We're investing in what we believe at a UK level is the best hope, the best version of that. And then with the WHO procuring for the whole world and all the drug companies coming together scientifically using Edinburgh, Glasgow University, others to get that research bit better. So that one day, and this is the moonshot idea you've read in the paper, one day there may well be a test that you can do at home for this coronavirus, as long as it doesn't mutate away from us, that will tell you whether you've got it that day. Just now, we just simply don't have the science to be able to do that. My final point is that fast testing will be best at bedside. So the first place we will use fast testing is for the treatment of people with COVID. Let's remember, in amongst all the asymptomatic testing of students, in amongst all the talk of care home testing for staff, the most important people are the people who have the disease. And everything that we can do to help them should be our number one priority. Then we should, of course, stop people getting the disease, which is the next thing you would use testing for.
Okay.
Thanks, Mark. Just to say to everyone, this evidence session has taken slightly longer than expected, and I hope it's all right with both colleagues and our witnesses if we drift on beyond 11:30. And if it's not all right, if anyone has an issue with that, please could they either let the clerks know or type it into the event chat. But I don't want to go too fast for the members yet to ask questions, if you see what I mean. So with that in mind, can I turn next to Shona Robertson?
Thanks, Convener. Good morning, everyone. I want to turn to the health harms identified in the route map, and specifically around the recent Public Health Scotland figures that have come out that are showing that cancer referrals have dropped by a fifth in the 3 months after lockdown compared to the same time last year. So it's really to ask the Cabinet Secretary for Health whether she could provide an update on the remobilisation of cancer screening services in order to try and reduce that health harm.
Thank you very much. Of course, one of the statistics that we published yesterday is the 96% meeting by our boards of the 31-day target, which has been consistent throughout the pandemic and deserves a mention because it signifies significant work on the part of the boards and all those clinicians involved to continue to be able to do that whilst they are facing other challenges. The screening programmes, I don't have the exact dates in front of me, my apologies, happy to provide that to you, although I think we have published those. The screening programmes have restarted. We are almost finalised our cancer recovery plan, which has been pulled together with the engagement of key sector or condition-specific third sector organisations, as well as the Clinical Cancer Network, and we will publish that shortly, and that will give specific focused action to improve the patient flow through from those screening programmes, but also from first appointment with the GP through to diagnostics and then to treatment if that is what is required. We've also invested in additional CT and MR scanning facilities in order to make sure that we can speed up the diagnosis of this as well as other conditions as quickly as possible. And as you'll know, we are currently using NHS Louisa Jordan to provide early appointments and treatments, not for cancer, but certainly early diagnostic facilities as well.
That's a most helpful update. Thank you for that. I wonder if I could just ask you on another matter for an update on communication with the UK government on pandemic matters. And first of all, just to ask, are there meetings happening of ministers across all 4 nations? And if not, why is that the case? And just specifically, when you, Cabinet Secretary, last met UK government ministers to talk about the pandemic?
So I can certainly answer from the point of view of health ministers, and DFM may want to say something further about other engagement with the UK government. There are relatively regular meetings between the health ministers in Northern Ireland, Wales, myself, and the Secretary of State for Health. Roughly, it was weekly, every 10 days, every fortnight, as well as obviously constant engagement between our officials. Those meetings tend to involve just the 4 of us, with perhaps 1 or 2 officials in attendance, and we're looking at sharing experiences and ideas, as well as tackling particular problems. One specific example that may be helpful is it was very helpful that I was able to speak to my counterpart Vaughan Geffen, the Health Minister in Wales, about their experience with the Two Sisters outbreak that they had before we also experienced a similar outbreak with the same company in Tayside. So very helpful to be able to speak to Vaughan about their engagement with that particular company and how they had gone about matters there. So and as you know, our Test and Protect app has been built using significant support from colleagues in Northern Ireland and in the Republic of Ireland, as well as, I'm pleased to say, our capacity at the height of the first period of the pandemic to be able, through mutual aid, to provide PPE to both NHS in England and NHS in Wales.
Could I perhaps just add further detail just on the wider government engagement? I think it'd be fair to say that it varies a bit in different parts of government. I think in a number of portfolio areas there's a good amount of dialogue and discussion. The Health Secretary's talked about her dialogue in the Health Service. I've had a number of discussions with the Secretary of State for Education in the UK government and my counterparts in Wales and Northern Ireland. The Justice Secretary is involved in discussions which have become, thankfully, a bit more routine about some of the issues in relation to the quarantine arrangements and the exempt list for travel. I think there are other ongoing engagements that take place. I think the area where we have expressed concerns has been the rather significant absence of COBRA discussions, which thankfully was resolved and remedied in recent days. But I would say we attach a high importance to dialogue with our counterparts in the other devolved administrations and the UK government, and participate wherever that is possible to do so.
Thank you for that. Just finally, Deputy First Minister, I wonder if I could just ask you to give a couple of pieces of information of an announcement made today, a very welcome announcement about the new financial support package for people who are on low incomes and who are having to self-isolate and who would otherwise lose income. And as I understand it, the £500 support grant is going to be paid through the Scottish Welfare Fund, through local authorities, beginning on the 12th of October, which again is very welcome. And it's just to ask whether there'll be further guidance provided for the use of that and making sure that the demand is monitored, but also what work's going to be undertaken with employers to try and improve some of the employment working practices that perhaps have led to the very welcome grant having to be established in the first place.
Convener, there will be further details set out at the briefing later on today by the First Minister on the payments that are intended to be made. We obviously are determined to put in place the support that will be necessary to assist individuals in what is a very difficult time. And we certainly don't want to have a situation where people feel they are unable to self-isolate, which is is the building block of our strategy for interrupting COVID, because they feel that they are financially weak and are quite literally financially unable to do so. So those provisions will be put in place, and we are working at pace to make sure they can be delivered in the earliest course, because it is a crucial intervention. We're obviously working with employers to make sure that employment is made as sustainable as possible. We face a very challenging period with the changes to the furlough scheme that are coming forward, and it's vital that we have all practical measures in place that can ensure that individuals are able to be supported to play their part in the interruption of coronavirus.
Thank you, Convener. Thank you.
Thanks, Shona. Can I next turn to Willie Rennie? And Willie, if you have any interest to declare, could you do so before asking your questions, please? Thank you.
Thanks, Convener. No, I have no interest to declare. And thanks for giving me the opportunity to be on the committee this morning. The Scottish Government changed guidance for students just days before the start of term, and then chopped and changed after students had already returned to university. I'm sure the ministers understand that this has caused unnecessary stress for many students, many of whom have just left home for the first time. So some universities are handing back rent money if a student returns home. That's not available from every university. So are ministers prepared to step up and provide that level of support so every student in the country can benefit from that, whether they're in private accommodation or other halls of residence?
These are fundamentally, Convener, issues for individual institutions to take forward. We obviously are encouraging institutions to operate in a fashion that is sympathetic to students at what we recognise to be a very difficult time. Our core advice to students is, if they are able to do so, to stay in the campus accommodation to which they have moved. And some of them will have moved to that some time ago. Some of them will have moved to that accommodation over the summer. So many of these movements have been made because arrangements were put in place long before the guidance that the government has set out. So we would encourage students to do that, but we also insist upon universities providing the support that is necessary to individual students, particularly if they are self-isolating, to make sure that they are able to be supported in maintaining that self-isolation and in having all of their needs met, whether those are physical needs or support with cleaning and laundry, or whether it's about mental health support, or whether it's about medical support that is required. So we insist upon that from universities as an essential part of what universities must do to support individual students.
I would encourage the Minister to look again at this, because universities have obviously control over their own halls of residence and can support students through that mechanism in terms of rent. But there are many who are in private accommodation, and there are many universities that don't have the financial flexibility to be able to offer this kind of support. And this is fundamentally a problem caused by, I would say, the guidance that chopped and changed over the weekend. So perhaps the ministers could look at that again. But I do want to move on to the issue of asymptomatic testing for students that's already been covered. I'm frequently told, including by the First Minister, that the concern is about resulting behaviours from negative tests. And the assumption is that students and others will relax and ignore all the public health guidance if they get that negative test. And I'm just keen to understand where the evidence is to justify that position.
To begin with, and then my colleagues, I think, will wish to add to what I say. I think the Health Secretary made a point in her opening remarks, I think it was in her opening remarks, about the importance of listening to the advice that we receive on behavioural science, and we've had tremendous input into the government's thinking from Professor Steve Riker from the University of St Andrews, who has contributed significantly to our understanding of the importance of people feeling confident in the requirements that are placed on them and able to play their part in taking forward the guidance that is set out there. And so much of our success, and I made this point in my own opening remarks, so much of our success in dealing with COVID will come down to the contribution of individuals and the degree to which they comply with the guidance. So I can't stress enough the importance that we attach to ensuring that there is good understanding of and good compliance with the guidance that has been set out to make sure that every individual can play their part in that activity. Now, on the question of asymptomatic testing, I think the judgment that we've applied is that essentially asymptomatic testing may create conditions in which people feel that they are not, that they perhaps are not quite as obliged to follow the guidance as ordinarily we would expect that to be the case. And that applies across the whole of the population. So we put out that guidance, and we feel we should take that strong, apply that strong message to enable individuals to see the importance of making that contribution on a daily basis to keep themselves and others safe. But my colleagues may wish to add to the remarks that I've made.
I want to make a couple of points, and then we could go to Professor Leach if there's more that he wants to add. I think we need to take a bit of a step back here and just remind ourselves about what it is we're actually trying to do. Until we have a vaccine that has been clinically trialled and proven to work and is rolled out across the population, what we are trying to do is prevent the transmission of the virus, which is with us from one individual to another. So we need to go back to some of the simplest and most straightforward steps that each of us can take around washing our hands regularly and properly, cleaning hard surfaces, using face coverings, maintaining physical distance of 2 meters. These are the really important individual steps that each of us can take in order to prevent the virus moving from one person to the other. They're the core public health advice, the core tools, if you like, that each of us have. And testing is then added to that where it is appropriate and valuable in specific circumstances. So it is valuable in care homes in preventing the introduction of the virus from those individuals who go in and out of care homes regularly, the staff. So we use testing there every single week on individuals who do not have symptoms, but who from time to time do prove to be positive. But the proportion of those who prove to be positive against the overall numbers who are tested every week is very small. So testing of itself is not enough. What in those instances, as well as all those other measures I've described, in those instances, what those individuals need to do is all the work around PPE, effective infection prevention and control, and barrier nursing. So my point is really to try and help us remember the place that testing has. It is not a silver bullet. Following that basic public health advice and guidance is the closest we have individually and collectively to any kind of silver bullet. Now, Professor Leach has already spoken a bit about asymptomatic testing, but if he wishes to, Convener, he may want to add some more points to what I've and the DFM have just said.
I would refer Mr. Rennie to the previous answer and add one layer, which I think DFM and CABSEC have touched on, and that is there is a behavioural element to testing. There isn't any question about that. There is the science and the genetics and the bit I covered earlier, but there is a perception in all layers of society that if you are negative, you can go about your normal business. We know that. So students are not special. I'm not singling them out in any meaningful way. I'm not singling out any section of society. So if you introduce testing in some new layer or some new group, you have to be very clear what that test means. That's true of a mammogram, it's true of a CT scan, and it's true of a PCR test for coronavirus. What should you do in light of your negative or positive test? And that communication is absolutely crucial. The trick here is a negative test, unfortunately, is relatively meaningless about your individual behaviour. So you should still do the self-isolation if you're a contact. You should still do the population measures that we're all under. So that's the challenge around behavioural science, as well as, of course, the genetic science and the PCR science about what the test actually tells you.
Convener, one more quick one, if that's okay. I just wonder whether, with a large proportion of those who have got the virus don't know they have it, should we not be using testing in those cases, especially with young people like students, to try and hunt down the virus more and use the testing for that? I agree with everything that the Minister and Jason Leach have said about this is not a route to go back to normal life as it was before. This is an extra safety measure. My argument would be that because this is the biggest movement of people since the start of the lockdown, we need to take an extra step, at least just now, to try and snub out the virus in universities on top of all those public health measures that you've already talked about. Is there not an argument for that?
I think, can I make one comment on that? I think if we look at the number of tests that are being undertaken, I would contend that a lot of what Willie Rennie suggests is actually happening because of the degree to which increased testing is taking place in a number of locations, particularly with the addition, the very welcome addition of the walk-in centres, which have been established in a number of different locations in close proximity to universities. So I think the improved availability and accessibility and volume of tests, I think, contributes significantly to addressing the point that Willie Rennie makes. And then if we add on to that, the very strong message which we are taking forward in consort with the universities and crucially with the National Union of Students and with students' associations, but encouraging the good practice of following the advice, then I think that should give us some confidence that we are taking the measures to do exactly what Willie Rennie wants us to do, which is to, and which I want us to do, which is to ensure that we take all possible steps to contain the virus within those university communities, to eradicate it, and most importantly, to avoid it spreading into wider society. I don't know if my colleagues want to add to that.
So I'm fine, Convener. I have nothing more to add.
Jason, would you like to add anything else?
Only a single sentence. We asked our scientific advisory groups that exact question that Mr. Rennie's just asked, and the advice that came back to the Deputy First Minister was, at this stage of the pandemic, at this stage, constant review, and of course it will change if Cambridge proves something different. They said that was not their advice at this point, but we should send in more symptomatic testing, which we've done around Abertay, we've done around Glasgow University with mobile testing units, walk-through centres, etc., etc. So layers of testing, but not that population level asymptomatic testing.
Thank you very much. The next questions come from Willie Coffey.
Thanks very much, Convener. I wonder if I could ask a couple of questions, please, to Joan and Jean. They're really from constituents about the household and hospitality restrictions, and if there's any time at all, Convener, a question on the R number to either Jason or Richard. First question is, why is it we allow people to effectively be in the company of many other people in restaurants, pubs, planes and buses, all breathing the same air, all for greater than 15 minutes, when we don't allow a person to visit another person in their house? And the hospitality issue, the 10 p.m. curfew issue, if you're in a pub for a few hours or a restaurant for a few hours, why is it we think that we're safer if we leave at 10 o'clock than had we left at, say, 11 or 12 o'clock? So these are questions, John and Jean, that constituents have been asking me this week, and I would be obliged if we could try and help to set out our thinking about why these measures are necessary.
Let me go first with some responses. But essentially, the decisions that we've taken, particularly around household restrictions, which I can assure Mr. Coffey we have taken with great reluctance, has been driven essentially by the fact that there has been a growing evidence base within the work that's undertaken by Public Health Scotland that demonstrates that household transmission is a significant factor in the spread of the virus. So we are reluctantly having to put those restrictions in place in a very targeted way to try to address an element of transmission that we know from the evidence is causing significant difficulties. Now, of course, people can still, people from two households could meet up in a cafe or a pub or a restaurant, but those pubs, cafes and restaurants are obliged to follow, they are regulatory environments. They are obliged to follow very strict practices about how they deliver their services and how they manage their environments, which cannot be assured within a household setting. So that's the difference and the distinction on that particular point. And I think on the 10 p.m. issue, the sense that I would want to convey to Mr. Coffey is the fact that we feel that there are limitations and parameters we need to put around the degree of interaction that individuals can have. If that goes on in an unrestricted basis, then it may give a signal or an opportunity for the virus to be transmitted. If we put some constraints on that, it enables people to undertake some social interaction without the interaction being limitless and therefore challenging as a consequence. My colleagues will wish to add to that.
I guess I simply want to make 2 points, and the first is to reinforce what the DFM has just said. So when we undertake the testing, the NHS Test and Protect procedure, what we find as we do that, as index cases are interviewed and they tell us where they have been and how long they were there and so on, what Professor Leach has in the past described as themes emerge. Essentially, we begin to see where is the commonality in how the individuals have acquired the virus, where have they been with their contacts and so on. And that's one of the places, the key place where the evidence emerges about what looks like the dominant or one of the dominant areas where transmission is happening. And that has been seen consistently as within households. Now I absolutely understand. I'm sure Mr. Coffey knows that many constituents and family members indeed have asked me exactly the same question. And there's a bit of that I understand. It's in our own thinking that, why my house is clean, I look after everything, why can't people come and see me in my own home? And that is because in our own home, that is not, nor should it be, a regulated environment where we strictly maintain 2 meters distance, where we are very careful all of the time and how we are cleaning surfaces that other people have touched. It would not be a very welcoming home if everyone who came to visit me, if I followed them around with an antibacterial wipe, wiping everything that they touched immediately after they touched it. So I understand the reaction, but that is, if you like, the core explanation. The difference between our own homes and those hospitality environments is that regulation of physical distance, of sitting at tables, of wearing face coverings, of taking contact details, all of that, alongside the fact that the evidence that we see is telling us at this point that transmission is coming. One of the most predominant areas is through household transmission. And so if we want to stop that and break that, then we have to impose that kind of restriction on all of us, which is very difficult indeed to receive and to follow, but is really necessary if we're going to be successful in stopping the current virus from getting out of control.
Those are very helpful answers, John and Jean, and thank you for those. I wonder if we could ask another question, please, to either Jason or Richard. If the virus can accelerate from really low numbers in the population to very high numbers in a short space of time, how can we ever be in a position where it's no longer regarded as a public health risk, and for us to move to what we hope might be phase 4? And are there any countries that we know of that are now at the equivalent of phase 4 that we are seeking to get to?
What a fantastic question, Mr. Coffey. There are no countries that are at phase 4. There are countries with lower prevalence than us. New Zealand is the obvious example, but there are some others in Southeast Asia that the WHO is looking at very carefully. Even there, importation of cases remains a challenge. And you've seen Auckland close down in the last 6 weeks. You've seen Melbourne shut down in Australia, which had very low numbers. Until we get a clinical and scientific breakthrough, we are stuck with this virus. And even then, we will have to live with it in an endemic way, like we live with flu and tuberculosis and other infectious agents. I think we will live with this virus for many, many years, but we will live in different phases. So I am very hopeful that in the spring and summer of 2021, the world will develop a vaccine that will partly protect maybe all of us, maybe some of us, against the worst elements of this virus. But it will not kill the virus in the community. It will not get to a position where the virus no longer exists. The only thing will get us there is if the virus does something. That might happen, and if you were going to wish for something, that's what you should wish for. But there is no evidence that the virus is changing to get us into that position. So the only way out is a mixture of testing and treatment. So presently we have no way of stopping a mid-level case becoming a very serious case. We have no way of preventing you getting the disease other than your own behaviour. And we have no way of treating the disease if you get it, except right in the extreme. If you're in intensive care, we're getting a bit better at keeping you alive and getting you out safely from intensive care. But there's no meaningful treatment earlier in the journey. There's also no treatment, because we don't understand it yet, for those who get the chronic disease from this viral infection. So therefore, until then, and we've said this a number of times, until then, it's human behaviour and test and protect. And that's why you see me and my colleagues so worried about 600 people, 700 people, 800 people getting the disease, because that has implications for serious illness, and the health service can't get us out of that.
Okay, thanks very much for that, Professor Leach. Back to you, Convener. Thank you.
Thank you, Willie. The next questions come from Maurice Corrie.
Convener, thank you very much. Good morning, everybody, and thank you for coming to our committee. Following on from Willie Rennie's question earlier on relative to negative testing, this is a question for the Deputy First Minister. as we now enter the second 6 months of the restrictions in the pandemic, people could well become complacent, weary and slack about adhering to the necessary restrictions. What is the Scottish Government's plan, Deputy First Minister, to counteract this with some clever and effective communications?
I acknowledge the significance of the point that Mr Corrie makes, and the Government has taken a range of steps to make sure that we continue to maintain the highest possible communication and the clearest possible communication about the risks that people face and the compliance that is required to enable us to defeat the virus. That takes a number of forms. Fundamentally, it relates to the conveying of public information by the First Minister on pretty much a daily basis, which we have sustained throughout the pandemic and which we believe to be very important. And obviously, the broadcasting of that to the wider population is a significant part of that communication message. Secondly, we have very significant advertising and marketing campaigns that are designed to reach different groupings to enable that compliance to be undertaken. And crucially, and this is thirdly, those advertising and marketing campaigns are informed by significant research about the attitudes that prevail from individuals about the risks that they face and the necessity for their compliance. And obviously, where we see information, for example, where public willingness to comply perhaps is beginning to wane, we have to then rebalance the marketing to reach people who may find that message, who may be less likely to comply. So the recent advert, which colleagues may have seen, which revolves around paint being used to symbolise the virus, which is conveyed between a young woman and her grandfather, I would contend that that is a noticeably more aggressive communication, a blunter communication about the dangers. Well, that was designed as a consequence of our market intelligence, which indicated that compliance was perhaps not as acute and there wasn't quite the sense of the danger that we've just discussed in the questions with Mr Coffey about household transmission. And then fourthly and finally, we have anchored our message around the facts guidance that has been reiterated and reiterated and reiterated, and we will continue to do so because that is the foundation of the actions that we need from individuals to ensure compliance.
Thank you, Deputy First Minister. I think that's very interesting. And as a marketing man myself, I fully understand the messaging you're talking about, and I think it's absolutely right. But following on just further, Professor Leach made a very clear point in answer to Willie Rennie's question in the negative testing, is that we still have to adhere to the pandemic measures. How are you going to sort of target that very message? Because that's extremely important. And how are you going to encapsulate that in your messaging, Deputy First Minister?
Well, fundamentally, we have to anchor all of what we do around the facts guidance. If people follow the facts guidance, that will contribute. That is the best defence in relation to the spread of coronavirus, and if they observe that in all circumstances. So those are not abstract marketing concepts. They are fundamental tenets of guidance, which we are putting into a marketing message, and we are reinforcing it as effectively and assiduously and as comprehensively as we possibly can do. Now, the challenge in all of that, with which Mr Corrie will be familiar, is that people may become familiar with that message, but with their familiarity might also come tiredness with that message. We have to find different ways of reinforcing that message, and I would contend that the most recent distillation of that message through the paint advert is a pretty blunt way of doing that, but I think it's had an effect of reminding people of the dangers of not following that core advice that we've set out to members of the public.
Thank you, Deputy First Minister. That's a very interesting comment. I would strongly agree with what you're saying there, because it's something that we need to really drive home. Convener, can I just turn to another question, a final question, to the Cabinet Secretary for Health and also Professor Leach?
Of course.
It is to do with care home visitors. There are obviously concerns around the fact that only one nominated visitor is allowed to visit a care home resident, and it raises concerns with families. And clearly, we need to look possibly at some flexibility. And I understand all the restrictions. I understand the consequences, exactly what the Deputy First Minister has just been talking about in the spreading of the disease. But maybe is there a way that we could implement a system for close relatives to visit whilst wearing PPE equipment? And does the government have any plans to look into this as far as residents are concerned, which would benefit well from having family members to visit in general, but obviously in a very, very controlled fashion from that point of view? And I throw this open to the Cabinet Secretary for Health and Social Care and also to Jason Leach.
Thank you very much, Mr. Corey, for your question. It is a really important question. I'm very conscious of the unintended consequences of the restrictions on visiting that we have introduced, and even where we have eased those, the unintended consequences on both the residents of our care homes and indeed the staff, as well as the family and relatives. We're busy looking right now with our clinical and professional advisory group that looks all the time at everything that we are doing with care home providers and to both protect residents in care homes, but also to see what we can do by way of introducing more normal life to care homes. They are working hard at the moment, and I'm expecting their clear advice very shortly. I had a discussion with the care home relatives group about just over a week ago, and again we'll discuss with them later this week what I hope will be a proposition that allows for a couple of things: for the designated visitor to be able to visit more frequently and for longer, with appropriate protection and so on, and with appropriate responsibilities on them if they have any symptoms of any infection, but particularly COVID, not to go, and also so to be with their relative for more often, for longer, and to reintroduce touch, the opportunity to give your mum or your dad or your aunt or your brother, sister, whoever, a hug, which is really important. I think all of us probably recognise very, very well the absence, the impact on us of the absence of that physical touch from family and friends that we're just not engaging in right at the moment. So I'm hopeful that we will be able to do that. It is I know you appreciate, a really difficult balance between continuing to try and ensure that we're protecting a group of people who are vulnerable to serious harm from the virus, at the same time as recognising the other harms that can be done by that level of protection. So trying to get that balance right, as well as what we have also done, which is reintroduce the return of health and care services to care homes, always with the proviso that the care home itself needs to be COVID-free for 28 days and needs to be participating in that care home staff testing programme that I spoke about before. But it's a very, very important issue, and I'm glad you've raised it, and I really do hope we'll be able to make progress very shortly.
I would only add that I think of all the restrictions that we've had to advise about, this is the toughest. This is literally the hardest piece of the public health response, because everywhere you look, there is harm. Harm from COVID, harm from loneliness, harm from dementia, harm from family connection. To try and find a compromise that gets us to somewhere in between all those harms has been enormously difficult for every single country, including ours. We have made progress, and we've tried to do that gradually and safely, and the Cabinet Secretary for Health, I can absolutely promise you, has called in all the people she needs to make those decisions wisely. I would just add a fairly blunt statistic in balancing some of those. So my desire to get families back, my desire to get myself back to friends and family who are in care homes. You have to give this virus to 10,000 under 20s before somebody dies. You have to only give it to 6 over 85s before somebody dies. So that's a pretty stark warning about how crucial it is to do this safely. That's not to suggest remotely that we should leave people to be lonely and we shouldn't look after them. We of course should, but we should absolutely redo the visiting, start it again only when it is absolutely safe to do so.
Thank you, Professor. I think it's a very stark statement that at the end there with the statistics. And back to you, Convener. Thank you very much.
Thanks, Maurice. Our final set of questions come from Annabel Ewing.
Thank you, Convener, and good morning to our panel and colleagues. I have to say it's been a very interesting discussion. The takeouts, I think, are fairly gloomy, to be honest. But that's where we are. I had a number of questions, but they've been asked and answered, so not to detain everybody unduly. Place to finish. And I'm thinking in particular, and it involves communication as well, I'm thinking in particular, I was very struck by comments that Professor Leach made, I think it was yesterday, during the First Minister's daily briefing. And it was very much informing us and reminding us that this is a global pandemic, and providing us with an update on statistics from across the world in terms of number of cases, sadly number of deaths, examples of what was happening in other countries. And I seem to recall that at the very early stages of lockdown, where buy-in was absolutely amazing in Scotland and compliance, we were very much aware as citizens that we in Scotland were part of something that affected every single country in the world. And I just wonder, perhaps for the record today, if Professor Leach could provide such an update for our committee's purposes, and if I could then ask the Deputy First Minister if the government will reflect on how we can continue to bring relevant information about the international context to the attention of the people of Scotland. Because I think sometimes there's a risk that we feel that what we're doing here in Scotland is too generous, has nothing to do with anything else. And we forget that we are in the midst of a global pandemic, and that every citizen of the planet will not come away unscathed, be it in terms of health issues or economic issues and or well-being issues. And I think that's a really important picture to have to bring to people's attention, because I think then it helps to put things in a context, and it helps to facilitate compliance when, of course, we're approaching the winter months and we can see how weary people are getting. So perhaps I could go first to Professor Leach and then to the Deputy First Minister. Thank you.
I'm very grateful. You're very, very generous. Yesterday was an appropriate day to talk about the global pandemic. Because in the early hours of Tuesday morning, the world crossed 1 million deaths. 1,055,000 people have died following a positive COVID-19 test. We know a number of them have been in Scotland. So it was appropriate to try and put that in context, I think, and that's what we did yesterday. And when I came home, my wife said that I was a little emotional at the podium, which is unusual. Most people wouldn't have spotted it, I don't think, but she did. And she was right. It is not without emotion. And we shouldn't, I don't think, remove that from the communication or remove it from the messaging that we're trying to spread around the country, be that in an article in the Oban Times or on the phone-ins on Radio Scotland in the morning. And I think in the communication answer earlier, the Deputy First Minister talked about multiple messaging to every sector, and we have had to change the way we do that. And relation to the global pandemic is one element of that. So to put that in perspective, there is no European country just now not thinking about extra restrictions. The Dutch is the most recent example, where they've had very restrictive hospitality measures in the last few days. They've restricted household gatherings. They've banned sports crowds. You're not allowed more than 4 people in hospitality. Other countries have gone to 1 household only in hospitality, so you can't mix at all. France, in Paris and 11 cities we discussed yesterday, they now have a curfew at 10 o'clock, not unlike ours. But in the south of France, in Marseille, where intensive care is now full, they have shut hospitality in its entirety. There were numbers yesterday in France that suggested now it's 60 million people, so you kind of have to divide the numbers roughly by 10 to get to Scotland's population. They have 1,203 people in intensive care. Our conventional intensive care capacity in Scotland is about 120 to 150. And it's not waiting for COVID patients, remember. It's full of people with cancer, with major trauma, with road traffic accidents. We have more capacity than that presently because we've got ready for COVID. But that would mean another 120 people in intensive care. And once you're in intensive care, you've got a 50-50 chance of living or dying if you have that level of COVID. My final international comparison, Convener, would be Spain, and it is pretty bleak, and it speaks to what Scotland is doing just now and why it is doing it, and it's crucial. 9 weeks ago, the over 80s made up 8.2 per 100,000 cases. Then 6 weeks later, they were 75 per 100,000 cases. And 3 weeks later, 1,200 people died. So the virus makes its way through the demographics. The over 85s are probably not in the hospitality sector or mixing a whole lot in other people's households, but the virus eventually gets to them. And that's why acting now, and that's what the committee has been asking about in the early questions. Why act now? Why do what you're doing now? That's why. Because we don't want to be the French and Spain story that we're watching. And we can learn as we go. I'm sorry to be so bleak.
Convener, if I could make some remarks just to add to what Professor Leach has said in response to Annabel Ewing's question. One of the remarks I made earlier on was the government is reviewing data and information on a daily basis, if not several times a day. And the Health Secretary and Professor Leach and I have been involved in a number of discussions where we have looked very directly. And the most recent conversation, I think, I'm just not getting my days right, it must have been Monday, was we were looking very directly at the French and Spanish data, but then looking at how our data looks in comparison with their data over the course of the last couple of months. And when you plot the Scottish data with the French and Spanish data, we are following a fairly similar course, although we are several weeks behind. So when people say, why are you acting as emphatically as you're acting just now, that's the answer. Now, I think Annabel Ewing raises an important question about perhaps the debate would be in the discussion and the compliance would be enhanced by perhaps sharing more of that international comparative information. And I'll certainly take that point away and reflect on it. But I would assure the committee and Annabel Ewing that we are looking at all of that data to inform the judgments that we need to make to ensure that our actions are as effective, as timely and as emphatic as they need to be to protect the population from the very obvious dangers that Professor Leach has just set out.
I thank the Deputy First Minister for that answer and for the answer given by Professor Leach. And I am I'm very assured that indeed this international data is being looked at constantly by the Scottish Government. I do feel, though, it is important that there's greater communication of that so that we in Scotland recognise that we are we're global citizens, and decisions here, are not being taken in a bubble, and we've all, got to get through this somehow. And if we all pay attention and do what we need to do, the quicker we'll get out of it. So I'm very pleased indeed to hear that the DFM will take that communication point back and reflect further. Thank you, Convener.
Thanks, Annabelle. I don't know, Mr. Fogo, whether you want to add anything to the discussion. We've avoided coming to you, but I didn't want you to feel as if you'd been ignored. So I don't know if you've anything to add to what's been discussed.
Thank you. No, I don't. It's just always difficult to be alongside Jason, who is such an overwhelming expert. But thank you for coming to me, and thank you for inviting me. And I'll be very happy to contribute to future discussions if you would find that helpful.
Not at all. Thank you very much. Can I thank the Deputy First Minister, Cabinet Secretary for Health, Professor Leach and Mr. Fogo for their evidence this morning. It's been a very wide-ranging but helpful discussion. That concludes the public part of our meeting this morning, and I now suspend the meeting and ask members to join the next agenda item on Microsoft Teams. Thank you.